Well, good evening, everyone. My name is Tim Lenartovich, and I am the Director of RNAO's Nursing and Health Policy Department, and it is my absolute pleasure to welcome you to the third in a series of webinars to introduce RNAO's groundbreaking Mind the Safety Gap in Health System Transformation, Reclaiming the Role of the RN report. And we're very pleased that you can join us this evening. As I mentioned, this is the third in a series of webinars. The first two webinars were held in the past, and they were recorded, and you can access those at our Mind the Safety Gap website, and we will include a link in the presentation when we begin. I should also note as well that this webinar is being recorded, and this is to allow for colleagues who were unable to make it tonight to be able to participate, or to at least have an opportunity to review the presentation, and if there are questions or follow-up, they are more than welcome to engage with us directly. And so the way that we've had things set up here is that we're very pleased to have RNAO's president, Carol Timmings, joining us for some opening remarks. After that point, I'll then turn things over to Anastasia Harapol-Yap, who is a nursing policy analyst at RNAO, and she will lead us through the presentation. She and I together will work on responding to any questions, comments that you have. Now, given that we are expecting a number of people to join the teleconference, we're going to ask that you use the WebEx to provide us with your questions. It's just easier in terms of organizing that portion of the discussion. And if for some reason we can't get to all questions or comments, we are happy to follow up on those that we received that we are unable to get to, but I am hopeful that we can address all of them on the webinar this evening. So without further ado, I will turn things over to Carol Timmings. Carol is RNAO's president, and Carol has a very long and outstanding career as a nurse leader in public health in the community, and certainly has been quite involved with us along the journey with moving forward with Mind the Safety Gap. So Carol, we're very happy that you can join us this evening, and I'll turn things over to you.
Well, thank you so much, Tim, and it really is a pleasure to be able to welcome members to our teleconference or the webinar this evening and have the opportunity to discuss RNAO's policy report, Mind the Safety Gap in Health System Transformation, Reclaiming the Role of the RN. Some of you may recall that at RNAO's 2015 annual general meeting, we announced that we would begin work to address the concerning trends that were occurring in Ontario's nursing workforce. And so we spent a year analyzing health system priorities from the Patients First initiative and juxtaposing them with trends in nursing human resources, population health, and evidence on nursing skill mix and organizational models of nursing care delivery. And I must say that our findings are quite shocking. So as we move through this webinar, Tim and Anastasia will be sharing the findings of the report with you, as well as the recommendations RNAO has issued to position the nursing workforce in a direction that we believe truly puts patients first. So the Minister of Health and Long-Term Care, Minister Hoskins, recently tabled bold legislation to begin the implementation of his plans for health system transformation. This bill draws upon the plans outlined in the three Patients First documents released in 2015. As discussions regarding this bill advance, this policy report can be used as a tool to inform its refinement and implementation. So I encourage and welcome all of you to become involved in this important process. I will also commit to you that RNAO will continue to be at the forefront of this issue and of influencing and guiding system change so that we truly are putting patients first, and in order to do that, reclaim the role of the RN. So thank you for the opportunity to just share those brief remarks with you by way of welcome. And I will now hand it over to Anastasia and Tim to begin the presentation.
Great. Well, thank you so much, Carol, for your opening remarks, as well as for participating this evening. I'm going to turn things over to Anastasia, who will walk us through the presentation, and I will take things back over when we get to the recommendations, and together Anastasia and I will be happy to answer any of your questions. So Anastasia, over to you.
Thank you very much, Tim, and thank you all for joining us this evening. The webinar will begin with a 30-minute presentation about the Mind the Safety Gap report, and then we'll have time for question and answers. So to begin, we would like to share the current state of the nursing workforce in Ontario. So the largest share of the workforce is registered nurses at 96,000, and according to regulation, RNs can care for any client, including those that have complex needs, are less predictable, and being cared for in unstable environments. We also have about 39,000 registered practical nurses in the workforce, and they are prepared to care for patients that are less complex, more predictable, and being cared for in more stable environments. 2,400 nurse practitioners complete the workforce, and they build and expand upon RN competencies within their specialties, and some of their expanded duties include being patients' most responsible provider and attending roles in long-term care, to name a few. All nurses have an important role to play in the healthcare system, with appropriate utilization being key. And so RNAO monitors nursing human resource numbers and trends by analyzing data from the College of Nurses of Ontario. Of concern, the share of RNs across sectors has significantly decreased, with the exception of public health, where nurses are legislatively required to be public health nurses. And this trend has been confirmed by the latest statistics from the Canadian Institute for Health Information, which places Ontario with the worst RN to population ratio in Canada. And so now I'll move on to the current policy agenda, which is about redesigning the health system around the needs of Ontarians with the objectives of optimizing quality, outcomes, and returns on investment. And the government has proposed doing this by shifting care to the community, which is where patients and people would like to receive their care anyway. So this shift in the community is occurring during a time where demographics are changing, patients have more complex health needs, and technology is changing the way we provide care. And this shift is not just a shift in where services are provided. It's reflective of a broader shift from a reactive, illness-focused health system to one that is proactive and addresses health holistically and supports wellness. So as the health system makes this shift, it means hospitalizations will be shorter, patients in acute care will be more complex, and then they will be discharged to the communities and long-term care with more complex needs. This shift is also occurring at a time when the RN scope of practice is changing and expanding to include independent RN prescribing, as announced by the Minister of Health and Long-Term Care at RNAO's 2016 AGM, and the NP scope of practice will also be enhanced, as well as public health and primary care, to meet the objectives of the current policy agenda. So while RNAO supports the current policy agenda for health system transformation, which has been strongly influenced by our ECHO report, we are concerned that no provincial, interprofessional, Health Human Resource Plan has been developed to actually fuel these changes. We need to be asking, what are the trends in population health needs? Where will the health system be in 2, 5, 10, and even 20 years from now? And how will the demand for health human resources across sectors change in parallel in terms of supply, distribution, and utilization? It's no secret that organizations are facing budgetary constraints, and nursing is a large operational cost that is erroneously considered by some as low-hanging fruit to cut costs. Some organizations are making changes to nursing skill mix and organizational models of care delivery to meet their bottom lines today. But this has a significant impact on the workforce's capacity to respond to health system transformation efforts that are being implemented. To achieve the patient's first vision, and legislation has already been tabled to begin its implementation, as Carol alluded to, it is critical that decision-making be driven by evidence, quality, safety, and optimal patient outcomes, not budgetary constraints. So we've seen a wave of headlines identifying organizations that are replacing RNs with less qualified providers. And whenever RNAO receives concerns from members or sees these types of headlines, we always connect with the chief nursing executives at those organizations. We want to ensure that our understanding of the situation is accurate, and if we have safety concerns, we do have an obligation as an association grounded in evidence to speak out, which we have done and which we will continue to do. And so although this slide highlights what RNAO has done in response to RN replacement, it really reflects what you, our membership, have done. We have to give a big thank you to all of our members that have responded to our action alerts on stopping RN replacement and implementing the recommendations from this report, which we've had over 21,000 respondents between the two. Members have also participated in our 2016 Queen's Park Day and Take Your MPP to Work event where nursing HR issues were key priorities. Our members have also tweeted and shared about these issues on social media and participated in the dissemination of the Mind the Safety Gap report. So now I would like to present RNAO's model for health system effectiveness. There are 4 pillars necessary to achieve the optimal health outcomes that result in health system effectiveness, and these are evidence-based policy and practice, full and expanded scope of practice utilization, interprofessional practice, and health human resource planning, which is the focus of this report. And so getting into the details of our Mind the Safety Gap report, in this report we conducted a 10-year trends analysis of nursing workforce data, an analysis of population health needs, a historical overview of the nursing models of care delivery, and an analysis of health system priorities. And our aim was to understand what population health needs in Ontario are, where the Ministry of Health and Long-Term Care wants to go, and how the trends in nursing either align or disconnect with health system priorities. And we found that the current trends within the nursing workforce do not align with where the health system is going, and so we reissued an urgent call for an interprofessional health human resource plan for Ontario that would follow a transparent, evidence-based, and engaged process. For the Mind the Safety Gap report, we did a thematic analysis of the 3 Patients First documents released in 2015, and we identified the priorities by identifying key themes that were consistently presented in all 3 reports, and these included reorienting the health system within community-based care, increasing public transparency, providing coordinated and integrated services that match population health needs, and monitoring health system performance, and improving accountability. And so for a more detailed explanation of how we arrived at these themes, please refer to Appendix A in the report. So bringing it back to nursing health human resource priorities, we see 4 key nursing priorities as contributing to these 4 policy priorities. This report will focus on the first 2, with appropriate nursing skill mix utilization, about ensuring that skill mix distribution aligns with patient needs, as well as the individual nurse's knowledge, competencies, and skills. We also see organizational models of nursing care delivery that advance continuity of care as crucial to achieving the policy priorities. Maximizing and expanding scopes of practice have been covered in other RNAO policy work, including submissions to HPRAC, and evidence-based practice is covered very well by our International Affairs and Guidelines program. And so this slide refers back to the broader shift in the health system that I alluded to earlier. And so our health system is going from an illness-focused system to one that addresses health and wellness holistically. But in order for this to happen, we need a system that includes robust public health services, including public health nurses, coordinated primary care, social and environmental determinants of health, and health equity, and effective skill mix and organizational models of nursing care facilitate this shift. So due to the historical reliance on illness-focused care, patient complexity is increasing. In the past, despite the incredible efforts of public health, there has not been enough support at a systems level to address social and environmental determinants of health. And this has resulted in a population with chronic diseases, comorbidities, and complex needs. Although the complexity of care is increasing, the share of RNs in the workforce who can safely care for complex patients has decreased. While the share of the RPN workforce rose from 21.5% to 28.4% from 2005 to 2015, the share of the RN workforce has significantly decreased, and now Ontario has the lowest RN to population ratio in Canada at 711 RNs per 100,000 people versus the Canadian average of 841 RNs per 100,000 people. So for this report, we also conducted a literature review to synthesize the evidence on nursing skill mix. And while we did include evidence from researchers in Ontario, the scope of our search was international. We looked at other comparable developed nations, and we also pulled the best literature from experts in this field. And the evidence is clear. Replacing RNs with less qualified providers results in increased mortality, readmissions, adverse events, lengths of stay, and transfers in care. It's also associated with decreased continuity of care, quality, safety, and satisfaction. And now this slide addresses organizational models of care delivery, or more specifically, how the different categories of nurses are utilized in care provision. In primary or total patient care models, one nurse cares for a small group of patients. The most appropriate nurse is matched to the client's complexity, predictability, and stability. Whereas conversely, in functional or team-based models of care, patient care is divided into tasks and parceled out into a group of providers that could include RNs, RPNs, and unregulated care providers. And as the shift from total patient care models to functional models or team-based models happens, continuity, efficiency, safety, quality, and patient satisfaction is lost. RNAO believes that the model best aligned with continuity of care and care providers is primary nursing, where individuals are assigned to the most appropriate nurse, whether that be an RN or RPN, who acts as their primary nurse through the entire care process and provides all aspects of nursing care. And this model of primary nursing is different from models of total patient care because the same nurse maintains their patient assignment over subsequent shifts to maintain that continuity. And so when we look at the evidence on models of nursing care delivery, the evidence is also clear. Over the past few decades in Ontario, nursing models of care delivery have endured cycles, switching between primary care models and functional or team-based models. And the research shows that functional or team-based models result in increased hospital-acquired infections, time spent in administrative tasks, fragmentation of units, hierarchical care teams, inequitable workloads, liability risk, and adverse events, and it also results in less psychosocial care, clarity of accountability, continuity of care and care provider, and productivity. And so now that we've had an overview of the key findings of the report, I will pass it over to Tim to talk about the recommendations.
Great. Thank you, Anastasia, for providing such a comprehensive overview of the report. And certainly, if you haven't had an opportunity to delve into the details of the report after the webinar, I would really encourage you to do so. But to further your flavor of the report, I'm going to provide an overview of the 8 very carefully crafted recommendations that are being offered by RNAO. And the first is recognizing that we're on the cusp of bold transformative change in the system and the need to ensure that we have a provincial evidence-based interprofessional health human resource plan that will align and connect what are the needs of health needs of a population with the full and expanded utilization of all regulated health professions and system priorities. And in absence of that plan today, we're calling on the Ministry of Health and Long-Term Care with the LHINs to issue a moratorium on nursing skill mix changes until a comprehensive plan is in place. So if we don't know where we're going 5, 10, 15, 20 years down the road in terms of health human resources planning, certainly it would be short-sighted to make any changes to a nursing skill mix. As well, given the significant evidence base that supports organizational models of care delivery that advance care continuity, we are calling for those models to be mandated, as well as to avoid the use of organizational models of nursing care that fragment care. In addition, given the evolving role of healthcare organizations and health system organizations, looking at the role of the hospital, given the emphasis on increasing discharge as soon as possible, there really should not be in the future any patients in hospital that have stable or predictable needs because those can be managed within the community. Therefore, we are calling for the Ministry of Health and Long-Term Care to legislate an all-RN nursing workforce in hospitals effective in 2 years for tertiary, quaternary, and cancer care centers. Now, these are known as Group A and D in regulations under the Public Hospitals Act, and an appendices is included within the Mind the Safety Gap report to identify which organizations we are referring to. But in summary, these are organizations that by default are designed to care for those with who have the greatest complexity of care requirements. And then within 5 years, we're calling for this requirement to apply to large community hospitals. These are referred to as Group B hospitals in regulations under the Public Hospitals Act, and a detailed listing of those is also found within the report. And the reason why we've expanded this requirement to these hospitals is because often these are hospitals that offer a high degree of specialized care. They are referral centers, regional centers, that a number of smaller hospitals will feed into, and often they do have affiliations and connections with academic institutions. Now, although we're calling for an all-RN nursing workforce, I want to clarify as well that we're talking about RNs working together with an increased number of nurse practitioners as well as clinical nurse specialists who are practicing to their full scope of practice. The complexity of care needs are also going to increase within the community. More people will be supported to live and to manage care requirements within their homes, within their communities. Therefore, we're calling on LHINs to require that all first home health care visits be completed by an RN. This will enable the RN to perform a comprehensive intake assessment of that individual and to begin to develop a care plan for them that will include assigning the full care either to an RN, an RPN, or an unregulated provider, depending upon what are the needs of that particular client. We're calling on the ministry, LHINs, and employers to jointly eliminate all barriers that prevent nurse practitioners to practice to their full scope. Instead, we want to enable them, including authorizing NPs to prescribe controlled substances, enabling them to act as most responsible provider across sectors, fully implementing their legislative authority to admit, treat, transfer, and discharge hospitalized patients, as well as to begin fully utilizing the role of the NP anesthesia, including intraoperative care. Our seventh recommendation applies to the long-term care home sector. Again, given that hospitalizations will be shorter, people will be discharged into long-term care homes with more complex needs than ever. Long-term care certainly has a tremendous role to play within the health system, and we should look at how can we improve their capacity to be able to deliver service and to keep people well within the homes. There's a lot of expertise there. But we're calling for minimum staffing standards within the homes, and this includes no less than one attending nurse practitioner per 120 residents, and a nursing workforce that is comprised of 20% RNs, 25% RPNs, and 55% personal support workers. And then last but certainly not least, we're calling for LHINs to locate the current care coordinators who practice within CCACs within primary care. And this certainly is a long-standing position of RNAO and was introduced in our ECHO report. These care coordinators, approximately 3,000 of whom are RNs, have a vital role to play within the health system. They are educated to provide comprehensive care coordination services, and we want to enable that capacity within the system and really transition away from a service brokerage to offering comprehensive care coordination. And we know that a hallmark of a high-performing health system is within its primary health care setting, and that there certainly is a wealth of evidence both within academic literature and as well as international experience that validates that RN-led care coordination within primary care makes a significant impact on the health and well-being of people. So that is an introduction to the Mind the Safety Gap report. Now, when I began the webinar, I indicated that I said that there's a website that we've created. It's actually a subpage of RNAO's website, rnao.ca/mindthesafetygap, and on there you will find a number of resources, including the report itself, as well as supporting media coverage, and these archived webinars are all placed on there. And so please use that website, share it with friends and colleagues. My contact information is included, as well as that of our CEO and Dr. Doris Grinspoon, who was also very instrumental in the development of this report. And I would want to recognize her contributions to this, as well as Anastasia's and Kim Jarvie, who is a senior economist within RNAO's policy department. But it really has been very much a team effort in collaboration with our communications department, as well as the countless number of members who have really worked with us to understand the issues, to understand what the solutions ought to be, and who continue to be with us. And I certainly want to recognize as well the outstanding leadership and dedication of RNAO's board of directors, who really are leading the way and helping to steer the organization to new heights. So how can you get involved? Well, some of the ways are first becoming familiar with the report and speaking about it to colleagues, friends, associates, signing RNAO's Phase 2 Action Alert, and I think we just sent a reminder, Anastasia, on Saturday. And so this builds upon the first action alert that we sent in 2015. And so if you haven't signed the second phase, we would encourage you to do so, as well as to become active on social media if you already aren't. Some of the hashtags that we are using for this report include Mind the Safety Gap, as well as Stop RN Replacement. And really that will help us to continue the dialogue. So on behalf of Anastasia, Carol, and myself, we again thank you very much for joining us this evening and for listening, I'm sure, intently to the presentation. So at this time, we will open it up to questions. And if you do have a question, we ask that you include it in the chat box on the WebEx. And I'm just going to give it a couple of moments for those who are participating to bring forward any questions or comments that you have. So we haven't received anything yet within the chat box, so I'm just going to, again, invite an opportunity. If you do have a question, certainly now you are more than welcome to provide it, or a comment, suggestion, concern, anything that you want to share. Well, Anastasia, I think that maybe we've done a comprehensive job and provided a lot of detail within the presentation. Now, if after you've had an opportunity to delve deeper into the report and you do have any questions, comments, or feedback, by all means, feel free to connect with myself or our CEO to share that. Now, again, I'm still seeing that within the chat box that there has been nothing that has been inputted yet. And given that, I think we will call the webinar to a close a little bit early tonight. We will have the fourth in the webinar series coming up. Anastasia, what's the date of that?
Well, that webinar will be held on June 15th from 12 to 1 p.m.
Great. And so for colleagues who may be interested but were unable to attend this evening, we certainly welcome your participation on that webinar. So again, on behalf of the trio here at RNAO, Carol Timmings, our president, Anastasia Haripul, and myself, we very much appreciate your attendance this evening and your involvement and engagement within the association. We hope that you found this a stimulating presentation, and we look forward to continuing to advance this work with you. So take care and have a great evening. Bye-bye.